worries at all. I know you're busy. This is Katie Chavez, by the way. I haven't had the pleasure of meeting you yet. I'm over marketing and communications for the Neuroscience Institute. So there are other folks listening in, but I do want to be respectful of your time, so we'll just jump right in. I did request this call. I know Mr. Stein did give me some insight on some of the items that you had discussed with him prior. But really the purpose, or what I think the purpose of this call is just to really help us position your marketing and communication strategy when you come on board with us. So,
sure.
Yeah, so I mean, I'll ask you a couple of questions. We'll make it just like a dynamic conversation. You can ask me questions. So, so really it's just to kind of get to know you. I know you've been with UCSF for, nearly 30 years, for a while now.
2 as a fellow and then 27.5 as an attending.
Oh, wow.
So 30.
Almost 30 years, that's awesome. Yeah. So it's a well-established program. I know you've helped build that one. Are you excited about the opportunity here, coming to Miami?
Yeah, starting from scratch, so to speak. Yes. So, big challenge.
Yeah, it's a relatively young program, but I think it has a lot of potential for sure.
Great.
Can you just, tell me a little bit about your specialty? I understand it's, adult brain tumors, including meningiomas and skull-based tumors, but just if you want to tell me a little bit more.
Sure. So I'm the primary and senior skull-based surgeon, but but my main interest clinically is meningiomas. Mm-hmm. So I've probably done about 3,000 in 27 years.
Wow.
And we have a great database. We're mining that to keep putting out papers, and I'll maintain an emeritus position, so that I'll be allowed to participate in the production of subsequent manuscripts because the university owns the information. So if I didn't have an appointment, I wouldn't, have access to that. But so we have a number of papers that are coming out still. My Dr. Hadley, one of my spine colleagues, told me yesterday that my H index went down by 1 to 71. But that's an indicator about how many times your articles are referenced in the literature and stuff. So above 30 is good, 50 is excellent. So I'm doing well.
You're doing fantastic.
So I got over 450 peer-reviewed publications, coming out with another book edited by me called Meningiomas. And so that's really been my clinical focus. And also I have a research collaboration and a named funded chair, the Wolf Family Chair in Meningioma Research.
I saw that.
And then I do other tumors like vestibular schwannomas, gliomas, metastases, have publications in all those areas. The about 25% of my practice is radiosurgery, which is what I was doing downstairs today. I'm co-director of the radiosurgery program and co-director of the skull-based program, and I do about 170 to 192 cases per year myself. Wow. The program does over 400 gamma knife radiosurgery cases per year. The advent of the ICON gamma knife, which allows for multi-session treatment, has resulted in about a 25% increase in patient volume. So that's been a good investment.
Great.
And the other thing I do is I do intramedullary spinal cord tumors with my spine colleagues. I do the bulk of the microsurgery, and I also help them with intradural extramedullary tumors that they ask me to consult on. And so that works out really well. We have some publications coming out on that.
That's awesome.
Another part of my practice, because nobody else wanted to do it, is I tend to see the normal pressure hydrocephalus syndrome patients. and we set up a screening program in a clinic, thankfully in the Department of Neurology, with a attending neurologist and a nurse practitioner. Nurse practitioner does all the history-taking testing, and she does the physical and psychometric testing pre and post large volume spinal tap. So if the patient gets a positive result from that provocative test, then they're referred to me, so I don't have to go through that again. It's just a discussion about to shunt or not. And we've written a number of papers on shunts, et cetera, and different techniques. So that's basically the clinical side. I used to do laboratory research, but that was 20 years ago, and it really wasn't that productive, and now it'd be completely non-competitive. You have to have a PhD scientist doing it in a basic science department, not in a clinical atmosphere. So, yeah, I mean, I think I was past president of the Joint Section on Tumors for the AANS CNS. I just finished my one-year term as the president of International Meningioma Society. I'm a member of the, the usual suspect organizations, well known, I think. A member of the Academy of Neurological Surgeons and Senior Society, North American Skull Base. So,
excellent. That's impressive, Dr. McDermott. We are excited. So if you don't mind, I'm going to, can I record this call? I think you're giving me so much great information.
Sure.
I mean, I write fast notes, but
no
I think you're giving me a lot of great information. So anyhow, so, I think in general, what do you hope to bring to this new program? I mean, in your eyes, what do you think that we...
Sure.
Yes, go ahead.
Well, yeah, for me, the main attraction was being a tumor doctor. The main attraction was the Miami Cancer Center. That is like a unique radiotherapy facility in the entire world. Absolutely. No doubt about it. There's nobody that has all those different delivery systems. And I actually
under one roof, right?
Sent a note to Pardon me?
It's all under one roof, which is impressive.
No, it's way more than impressive. It's amazing. And I've already put together the titles for 15 new papers that we're going to do with the group there.
That's great.
Comparing the treatment plan with the different delivery systems, primarily photon-based systems and the proton system. So I think that'll be really interesting. After discussions with Manesh Mehta and Rupesh, I said they were talking about how they do some planning on multiple different systems to decide which one gives the best conformity, sensitivity, specificity, etc.
Right.
And I told them you need to trademark the term differential radiotherapy treatment planning, because that's basically what they're doing, and nobody can do that. Nobody.
Wow.
So I think it's pretty awesome, and then they can do hybrid proton-photon treatments. That's not as unique because other places can do that.
Right.
But, I think Manesh has already been using that, so that'd be another topic to review and report on. And that's why I wanted a radiosurgery fellow, because I think there's just a gold mine of information and experience there, and getting publications like that out is what gives the institution program some notoriety.
Yeah, a leg up for sure.
So, yeah, and then the current faculty that are there, I mean, to be honest, they're general neurosurgeons. They're so busy with the ER work that they don't really have, Joby and
Spore.
Raul Justin don't really have a focus. So I'm trying to help them focus. Raul's obviously a total, spine fellowship trained neurosurgeon, so he's going to work spine. I've been talking to Mike Stein. I'm really hoping I can get my friend Mark Hadley to consider to come. He's a force of nature, and he'd be an outstanding senior leader for spine and would be able to work with John Uribe to set up a joint neuro-ortho spine center.
Yeah, I think Uribe would be really happy about that. That's
Oh,
been
yeah.
his dream for a while. Yeah.
Yeah, Mark's 100% in, all in.
Oh, wow.
And we have it here at UCSF as well, and I know what the model is and how it works.
Mm-hmm.
And I'd like to be able to, because, the spine thing is endless, as my chairman says. I mean, it's just, those guys are booked out like, 4 to 6 months.
Mm-hmm.
And our work is only booked out. The tumor world works on about the benign stuff can wait like a couple of months at the most, usually, if the patient's symptomatic.
Right.
But usually the malignancies, it's a 2 to 3 week cycle. So you'll have nothing booked for 3 weeks from now, and then you have a clinic and you're full.
Right.
And I think that's the problem for Vitaly Sioman, whose primary interest is open vascular, but he also does skull base. But he told me he was sending patients to the University of Miami because he had nowhere to put them. He was booked for 4 full weeks.
That's true.
So I'd like to, I think the system easily could handle a senior spine leader, 2 additional junior spine people. That's 4 in total. That'd be no problem. And they'd be busy right away. And then on the Kendall Hospital Baptist Center place, you'd have me, and I probably would focus on radiosurgery and then be a backup in the adult tumor world, because I got to bring up my younger colleagues and make them famous. It's not about me anymore. And I'd like Vitaly to be the director of cerebral vascular surgery. I'd like Justin to be director of functional surgery. I think I'd like Joby, who still wants to do degenerative spine, to maybe she could do like minimally invasive spine and spinal oncology. I haven't asked her yet, but she could be the neurosurgery lead in spinal radiosurgery, which is a huge up-and-coming area to replace open operations for patients with spinal column metastases. Way more cost-effective. It's way more pain-effective. And if the patients are not unstable, you don't need to operate on them. And their life expectancy is usually somewhat limited.
Right.
So I think that would be her being there and having an undeveloped spine radiosurgery program at the cancer center opens some opportunities.
Right.
The thing with the interventional people is somewhat of a more urgent problem that that they've been doing 1 and 2 for 4 years and they're basically exhausted. And so I think Italo is working on interviewing. Has interviewed one person. Is going to interview a University of Miami person.
I heard, yeah.
There's potentially somebody from Barrow Neurologic Institute who may be wanting to interview. So I think we have an opportunity to they've been doing it for 4 years. They can wait until another few months until somebody graduates, if that's really the right person. And I think I want to up the game a little bit and take people that have, good CVs, meaning, they're energetic, they're focused, they're productive. It doesn't mean they're going to we're not going to be opening laboratories or anything at Baptist, no way. But I want somebody with a good reputation. I want to make sure we don't just take a warm body for the sake of filling an on-call spot.
Right.
So, and then, through 3 to 5 years down the road, look back the numbers, review the program progress to date, see the areas that are, I'll bet you'll be able to hire more spine people because the place will grow. And
when you mention spine, are you mentioning neurosurgery side or physiatry side or both?
Yeah. Well, probably both. I mean, I think that but primarily the neurosurgery side. I mean, I have no doubt that as the population ages, there's a lot of. We just saw an amazing case yesterday, which of a lady, a 57-year-old, which is young, with a bad initial operation, whose neck, it was basically her chin was on her chest, because of certain things related to sagittal balance, and she got reoperated two procedures, and the pre and post-op profile of the patient. She's post-op for two procedures. She's standing there normally, and the deformity in her cervical spine corrected by itself with the reinstitution of proper sagittal balance. And I don't really understand all this stuff, but neurosurgery over the years has taken over in medicine the spinal reconstructive thing in adults anyway, not so much in children. And orthopedic residents, when they're training, it's primarily extremities and joints that they train in. They only do, 6 months of spine. That's it.
Wow.
Whereas we do much more of that when we're in neurosurgical training. Mm-hmm. And we probably lead the number of fellowships and the quality of fellowships for instrumenting the spine and deformity work currently. So it's been a complete about-face in the last 25 years for neurosurgery. We're doing pretty well in the interventional world as well, but still a little bit behind, but made a lot of progress. Mm-hmm. So I'm interested in getting so on the spine side, I think it's going to be spinal surgeons that will be required, and the numbers will go up. If you look at our institution here, the most common procedure on a monthly basis, single entity, is radiosurgery. We do, somewhere between 35 to 42 cases a month. And then if you look at craniotomy for tumor, we do about 28 to 34. If you look at spine volume, it's somewhere around 65, but it's many different types of procedures. So there's, cervical spine operations back and front, cranial cervical junction back and front, then there's thoracic, and then there's lumbar, and then there's instrumentation, then there's lumbar. So there's a number of different procedures in that 62 to 64 number of cases, and then there's 1, 2, 3, 4, 5, 6 spine surgeons on the neuro side, mm-hmm. and all the deformity cases are done jointly with an orthopedic surgeon.
Right. Oh, cool.
And if you look on the tumor side, there's 4 of us. So we're doing, the bulk of the, high 20s, mid 30s surgery, and it's usually big stuff. So stuff that's done skull-based combined with neurootology, and then we'd have to find a good partner in the head and neck surgery and neurootology to help us, and oculoplastic to help mm-hmm. us with some of the skull-based cases, and a plastic surgeon.
Right.
So, it takes a bit of work to coordinate this, but we don't have to hire all these people. I mean, there are other departments, and these individuals have an interest based on their training, and I'm sure they'd be glad to participate. So, lots of opportunities. The thing is just getting coordinated programmatically and identifying the correct people.
Absolutely.
To make up the team.
I think the exciting part about neuroscience and the Neuroscience Institute is that it really blends a lot with the cancer world, the cardiac and vascular world, and also orthopedics. So to me, neuroscience is very exciting because it does have a lot of overlap with a lot of the other institutes here, what we call Center of Excellences here at Baptist Health. So it's great. It's exciting. I think
I was just going to say that the thing I've been talking with Italo about is, once you get your helipad certified and operational, mm-hmm. I think the stroke volume is going to go up by, 50%, no doubt about it. Because you have so many outlying hospitals, and the timeline for acute intervention is, if you can get it under 2 hours, but certainly under 4, you can save a lot of people function, and I think that's going to be a growth industry for the center, the interventional group. So,
right, excellent. I was going to mention, we definitely would like to position you as a thought leader, in our own community and really throughout the nation. How do you hope to be recognized by colleagues, patients, and community leaders? What is your
right? Well, obviously, I think on a national level, I'm done in that regard because everybody, knows me from my previous work, and I've see, 90 neurosurgeons over the last 30 years, right? 3 a year.
Wow.
I think I know all the chairmen everywhere in the country. There's 109 programs. I mean, there might be one or two that I don't know well, but I know everybody at all the main centers. I think I have a very good reputation. So what I need to work on is the local and regional recognition.
Absolutely.
And, that's a matter of, I think, not so much going out to visit and give lectures, although that's part of it. I'm certainly anxious to do that because I think that works.
Mm-hmm.
But I was telling Mike Stein, one of our medical artists wanted to leave to go to Barrow, and I was trying to convince him to stay. And I said, look, you talk to the chairman about the money aspect, but I've got some other things I think we could develop that might be attractive to you and unburden you. One, I got him art. I paid for this out of my donation funds, which was a medical artist internship for him. We hired a part-time social media person. It was social media engineer, if you will. She's now full-time.
Oh, that's great.
So she does stuff with helping to edit some of the manuscripts and information that goes out on an annual basis to surrounding doctors about what the department's up to. We also have a full-time medical editor. But Melissa, who is the social media person, runs the Facebook, Instagram, and Twitter accounts that we have for her. She controls the content. She controls the text and all that kind of stuff. So I think that's worked out very well, and that was my suggestion. Awesome. It's been implemented.
Dr. McDermott, do you think I can be connected with Melissa so I can touch base with her? I think it'd be interesting for me to kind of talk with her, see what her strategy it looks like, so we can implement some of that over here.
And I think the other thing you need to do is I've looked at the the website for neuroscience, and it's not good. Yeah. So that needs to be. It's pretty simple. It needs to be redone.
Yeah.
And it's really easy, I think.
Right. So I mean, I think
you basically have.
As you're seeing it now, I mean, that's really. I guess all I can say is don't really pay attention to what you're seeing now, because all of that will essentially be going in the trash can. Okay. So we are, so I'll just give an update on really Baptist Health overall, baptisthealth.net, which is our principal website. All of that is going through an incredible overhaul, not just content, but really the flow of the website, photography, everything. So we're finalizing that, and then we're also going to the individual Center of Excellence sites. So that's Miami Cancer Institute, Miami Cardiac and Vascular Institute, Miami Neuroscience Institute, and Miami Orthopedics and Sports Medicine Institute. All of them are right now we're knee deep in content development. So what we've done, where we're at with neuroscience right now, is we're working very closely with the leaders, so Lindsay, Nate, to really identify subject matter experts that we're interviewing, so that we have the best relevant content, and we're identifying what it is that we want to conduct over phone interview, the experts. So obviously we've identified you as one of our experts as well. So I was actually going to mention on this call, if we can set aside some time, really to kind of go over the new site. So you can take a look at the new site map that we have laid out for the website. Sure. So you can give us, your feedback. So that would be excellent. Maybe, when you're here, because right now we don't have a live link for it. So we can sit down and really go over it. I think it's important, because obviously that's right now everyone's looking us up, online. So our presence to the community is, extremely important to our, potential patients and consumers. So, and then in reference to, social media, we, we're right now, we're doing, we're pushing out a lot of great content on our Facebook and Instagram, etc. But obviously we're open to suggestions. You can follow us on Baptist Health SF. So you'll see, though, we have the parent company, that pushes out relevant content, specific to different service lines. So if you look right now, we do push out a lot of cancer-related content, but I'm looking forward to, when you come on board, that we can push out a lot more neuroscience-related content.
Sure.
Obviously collaboration with the Cancer Institute, but we can do a lot of fun, a lot of great things.
Sure. Yeah.
Yeah. So we have over 13. Yeah, we have over 13,000 followers. So if you know Instagram, we actually now, if you hit over 10,000 followers, you can do the swipe up, which essentially you can be sent to directly to whatever, a YouTube link if you want to watch a video, or our site. But you only are granted that if you have over 10,000 followers. So a lot of our strategy, a lot of times, is through the parent brand, because we have a lot more eyeballs there. On Instagram, we have over 13,000 followers. So for us, it's important to push out content there, but we're open to, developing other channels as well.
Sure.
Yeah. So, so I'm going to continue with my questions as well. Sorry if I'm bombarding you with questions, but all of this is so helpful to us.
No.
What is your philosophy when it comes to patient care? How do you?
What? Obviously, that's our bread and butter. That's what we do every day. And I think, the key thing for surgeons is, not only providing excellent preoperative communication, intraoperative technical surgery, it's the post-op follow-up where the patients feel isolated and left alone. Nobody cares. They get a follow-up appointment in a year kind of thing. And that's, I think, where we kind of fall down a bit. I've been doing a quality of life study for meningiomas. I hope to continue that at Baptist. But I use my nurse practitioner on she helps me out a lot with communicating with the physicians, the primary care docs or referring docs of patients that I've operated on, saying, calling at the day of discharge, hey, just to let you know, your patient did fine, he's going home, but we don't have the final pathology yet, we're going to see him in 6 to 8 weeks, call if there's any problem. And then she sees the patient at 2 weeks, takes out stitches, looks at wounds, addresses any issues. I see them at 6 to 8 weeks, and then she'll call them. So when the 6 to 8 week appointment is coming, we're now at like 3 months post-op, and almost somewhere between 2 and 3. And then, depending on the diagnosis and how frequently they're going to come back, she will set up a little calendar with my secretary to make sure that she calls to check in, or she actually sends an email through our electronic medical record platform here, and there's something called My Chart, which the patients can use, and we can communicate with them and say, hey, Mr. McDermott, this is Jenny, Dr. McDermott's nurse, just checking in. How's everything going? We hope you're doing fine. If you have any questions, please call us. So, and it's a templated thing, and we get lots of responses to that kind of email.
Yeah, and it goes a long way, for sure.
It does, because on the patient quality assessments, it's always about follow-up, and that the surgeons don't really care once they've finished with you in terms of operating on you. So that's we got to work on that.
Right. No, that's fantastic. Is there a specific message that you consider, to be vital or important to deliver through marketing efforts?
Yeah, I think that what we want to do is make decisions for treatment based on a multidisciplinary cooperative group. And if you have a tumor, for example, that involves, considering surgery, radiotherapy, radiosurgery, brachytherapy, a number of factors. If you have a lesion that's causing seizures, you want to make sure that you don't, you get neurology involved to evaluate the patient pre, post-op, etc. It's not bad, but it's not our role to follow up patients for seizures. That's a neurologist's opportunity. So I think coordinating with the appropriate disciplines is key to getting a good quality outcome, and certainly the patients appreciate that for sure.
Absolutely. Can you tell us a little bit about what the future looks like for neurosurgery? What are you looking forward to when it comes to advancements in this field?
Yeah, so many facets, some of which I'm not expert in, but I'd say first that one of the areas for definite growth clinically and scientifically is functional neurosurgery.
Right.
So, and the advent of focused ultrasound treatment, the HIFU machine, which you're installing in the cancer center.
Yeah.
People are making a big shift away from the implants to using thalamotomy with the focused ultrasound, which is non-invasive, and getting very good clinical results. So I think that's going to be a burgeoning field for development. The hyperthermia can also be used currently it's used in research settings, but the University of Toronto group just presented their data on an animal model system for diffuse infiltrating pontine glioma, where they showed that if you gave a hyperthermia treatment before chemotherapy, it opened the blood-brain barrier and the drug got all in. For metastases, gliomas, they're using it as an experimental model for promoting reparative work in the hippocampus. So for patients with Alzheimer's disease,
right,
targeting the non-dominant hippocampus and treating it with sublethal doses to cause some degree of inflammation, which they're hoping will result in cellular responses, regeneration, repair, which will improve the patient's outcome. So that's at a research level. I think the hyperthermia thing and functional neurosurgery is going to be huge. The implant to control seizures, also a big area for growth. Seizure surgery is not going to go away.
DBS.
Most of the patients not DBS for seizure, but functional resections for patients with uncontrolled epilepsy. Most of the patients who are potentially candidates for surgical intervention never get it. 80% of them.
Wow.
And that statistic's been known for a long time. And there's some centers which are very aggressive surgically in epilepsy programs, and others which are not. And I think what you need to focus on is the data, meaning previous publications about what gives the best result, and follow that rather than some long-time practitioner's got a certain opinion about ways things should be done, but it's out of date.
Right.
That's the kind of thing.
Right.
So we try and practice, evidence-based medicine here, and it's resulted in changes in things that I used to do because of new data, and I just got to do it, got to make the switch.
Right.
So I think evidence-based medical practice is key, and it doesn't matter what area of neurosurgery you're talking about. But I think, functional neurosurgery, the other thing to think about, and I'm just getting a little bit of a taste of it, having been down there only twice, is the pediatric neurosurgery opportunity down there.
Yeah.
And you have a pediatric ER, you have a small pediatric hospital.
That's true.
I know I know via the grapevine that the pediatric neurosurgeons that are working, I think, where do they work? Jackson? Is it Jackson Hospital? Or what's the trauma center where they work?
Ryder Trauma, which is in Jackson. Maybe even Miami Children's, which is another Nicholas Children's, which is a children's hospital here.
Yeah.
They have
so it depends on what the population metrics are and what in Miami in general, and there may be an opportunity because of physician dissatisfaction with the way the practice is supported at the Miami Children's that you never know.
Right, you never know.
You have some of the infrastructure there already. I've put that on the back burner a little bit, but I wouldn't discount it. I think in year 2, that would be something to discuss with the pediatricians and the hospital executives as to whether or not they want to make a concerted effort. It makes sense to me if you've got the hospital and the ER.
Right.
The next logical thing. Do you have any other pediatric surgical services there?
So definitely in orthopedics, we have a pediatric orthopedic surgeon. I know Vasquez works hand in hand with him sometimes. His name is Dr. Saldana.
General surgeon, for head and neck stuff and
we have general surgery as well. Yeah. What we don't do is we don't
Yeah.
employ.
Lindsay's on the line. We don't do pediatric general surgery in our group today.
Okay.
Yeah, and we don't
you
employ
have a pediatric-
pediatricians either, right, Lindsay?
I'm sorry?
We don't employ pediatricians either.
No, we don't.
You can still
We have
take this
family
kind of
medicine.
pediatric. You can have a pediatric hospitalist. That's not a problem. It's a pediatrician who works in the hospital, doesn't and looks
Right.
after the patients in house. But do you have pediatric ICU?
I'm not certain. Lindsay, do you know?
If we do it at Baptist, I don't think we do. I don't think Baptist has it.
Yeah. So that'd be a
If
requirement.
they do, it's very small.
Right, it is.
Um,
It would be.
All right.
They've been making some changes in peds at
Yeah.
Baptist, but we could find out.
Yeah. It'd be interesting to look in the local population over the last 10 years to see what the proportion of the population is under the age of 18. I'm sure you can get that information.
I'm sure
And
we
then,
can.
if that's declining, then you can put the pediatric thing further on the back burner. But if it's increasing, then, there might be a demand and therefore an opportunity. So I would look locally at your population metrics and changes over the last 10 years.
Yeah, that would be interesting to see.
Mm-hmm.
And really, I think, lastly, and unless you have anything else to add, but on a personal note, just really tell me a little bit about yourself. Any fun facts, like your family?
Yeah.
Yeah.
Yeah. I had my wife was a nurse, and after the boys were born, we did the nanny thing, and that didn't work out, so she stopped.
Uh-huh.
Once the boys were grown, she went back to real estate. It was very cutthroat here, so she stopped.
Mm-hmm.
Then she's been in retail sales, like there's a houseware store which was called Hudson Grace. They're actually doing I don't know what you call it, like a pop-up, whatever that means.
Yeah,
I have no
that's
idea.
cool.
They're doing one in Coconut Grove because they were just bought out by Crate and Barrel.
Oh, that's awesome.
So she might do that. She's worked at in a high-end women's clothing place, and just for something to do, keep her busy
Right,
because the
that's
boys
awesome.
are gone. My older boy's 25, Brendan. He lives in New York, works for Blackstone.
Cool.
My younger boy, Christopher's 22. He's a senior at Ohio Wesleyan. They're both college lacrosse players.
Awesome.
And Christopher has a job in San Francisco when he finishes.
That's excellent.
Excuse me. And then me, I'm typically type 3A plus. I do a lot.
I know about those type A's.
I do a lot. I do a lot of stuff. Busy. If I'm not busy, I feel like something's wrong. When
Right.
I'm busy, I'm happy. I race vintage cars. I've been doing that for 22 years.
How interesting.
I like wine. I have my own wine label called Neurosurgery Cellars, which the Fed took away from me this year. So I'm going to bring it back.
Oh my God! Well, you'll be a little further from Napa, but doesn't mean you can't take a
that's
plane.
all right. No,
Very cool.
And I play golf. Used to play hockey, ski, and all that stuff, but I've cut back on all that. So.
Well, there's a lot of good golf
Anyway,
courses
okay.
around here, that's for sure.
Yeah.
Excellent. So I'm sure you guys are all excited to move to the East Coast.
Yeah. I just got an estimate yesterday from somebody, the first estimate about moving one car out there, because we're going to leave. My son's going to keep his car, or one of the cars, and then the other one I'm going to leave up in Sonoma. So,
Excellent.
But they already responded this morning with the estimate, so we're just waiting for that stuff to come in, and then we'll send you guys back the various estimates about the move cost and all that stuff.
Excellent. I'm sure your boys keep you busy.
Yeah, I've rented a house. I'm not buying anything.
Oh, good. Okay.
Rented, done.
Awesome.
January
Good.
1st, although we're not going to, so once we decide on the move, then, we'll pick a date. We have to be out of the apartment by January 31st. My last day of work is February the 21st. They have a going away party for me on the 22nd. And on 23rd, I'm going to get on, 23rd or 24th, getting on a plane coming out, and that's it.
Wow.
That's exciting.
Start March 2nd.
Well, we're
Monday.
excited.
Yeah, we're excited.
Yeah.
We're excited, and I know we're still planning your visit on the 10th, Dr. McDermott, where I know Mike's working on your itinerary for that visit. We've got a lot to talk to you about.
Sure.
That's great. And I know Lindsay mentioned that hopefully we'll have a little bit of time with you, obviously for your headshot and a video. So we've got a lot of fun things planned for your arrival.
Okay.
I appreciate your time, Dr. McDermott. I know you're busy, but it was nice to meet you via the phone. So we'll meet you in person soon, hopefully.
Yeah, and Katie, send me an email so I can hook you up with Melissa Lau.
That would be great.
The social media person. Okay?
That would be great. Thank you. Will do.
Okay.
All right.
Happy holidays.
Happy
New Year.
Yeah, Merry
See
Christmas,
you
everybody.
in a few weeks.
All right.
Thank you.
All right. Take care.
All right. Take care. Bye.
Bye-bye.
Bye.
Interesting. He's visiting in January?
Yeah, he's coming once a month, I think.
Oh, okay. Katie, do you mind if I'm on that call with the social media person?
I'm curious to see who this person is. It's someone who hired full time,
Full time.
like just for neuro. Yeah.
This is Kelly and Sadie.
What did they say?
Were they listening in too?
Yeah, they were on mute.
Oh.
Oh. Oh. Oh. Oh.